Good morning. My name is Rachel McInerney, and for my process improvement project, I chose to implement an opioid overdose program within a health department. As far as the background for this project is concerned, unintentional poisoning, as many of you know, due to drug overdose is the leading cause of injury-related death among Americans aged 25 to 64 years old, which surpassed motor vehicle accidents as the leading cause of death in 2009. From 1999 to 2016, North Carolina saw over 12,000 people die from opioid-related overdoses. North Carolina's Opioid Action Plan of 2017 to 2021 works to reduce opioid overdose deaths by 20% within the year 2020, with one strategy of making naloxone readily available. North Carolina's Department of Health and Human Services has identified health departments as instrumental in naloxone distribution. Of note, only 35 counties within the state of North Carolina, in which there are 100 counties, only 35 dispense naloxone within their health department clinics. The purpose of this project was to implement a naloxone dispensing program by using the state standing orders for naloxone dispensing in a health department located in Central North Carolina. For the methodology, there was a development of an opioid use screening form and standing orders for dispensing naloxone. There was also a development of a naloxone kit, which on the slide you can see a picture of the kit. Within the kit, it's an eyeglass case with 2 naloxone nasal sprays, 1 CPR mask, and a pair of gloves. Off to the side, you can see a tablet in which we were able to provide education to the clients that came in that wanted to receive a naloxone kit. They would watch this video, and then after watching the video, the nurses would then answer any questions that the client had, and from there dispense the naloxone. Prior to the implementation, the staff were trained on standing order, the opioid use screening form, and how to dispense naloxone out of the clinic's pharmacy. The project implementation started in May of 2018 and ended in July of 2018 for a total of 9 weeks. During this time, the PDSA cycle was implemented as screening forms were evaluated and audited weekly to ensure that the project implementation was going smoothly. There were some points at which the project goals, how to use the screening form, how to use the standing order, and how to dispense naloxone were reviewed with nurses and or administrative staff at different points during the project implementation. The numbers of clients that were seen in the clinic were compared to the numbers of the clients screened. Below this methodology section, you can see the outcomes section. For the period of 9 weeks, there were 410 clients seen in the clinic. 75% of these 410 clients were screened for opioid use. 25% of the clients that came in were not screened, so a total of 103 clients. The number of kits dispensed in the 9-week time frame was 13 kits, which is 4%. 307 clients were screened for the opioid use as mentioned before, and 13 of them wished to go home with a kit. As far as the impact on practice, there were many impacts with implementation of this program. The theory of plan change was followed and can be successful when implementing a new practice, and this was made evident by the moving and refreezing that was seen after the unfreezing. So for the unfreezing, this is part of Lewin's theory of plan change. The clinic that we are discussing now did not have this naloxone dispensing program in place. The health director, the clinic manager, the admin staff manager, the nurses, and the providers had to get on board with wanting to start this project. As this project was put into place, We then went through the moving stage. So the admin staff were checking in clients for naloxone dispensing. The nurses were screening for the opioid use. The providers were discussing naloxone kits with their patients, and the nurses were then dispensing kits if the clients were in need. As far as the freezing, we are now screening all clients for opioid use, and it's become part of our regular practice. We dispense naloxone kits if the client wishes to have one as part of regular practice. The PDSA model is also very useful in ensuring forward trajectory of projects. This model could be used by other health department clinics for implementation of any new project, any improvement project that they are wanting to start up within their clinics. And this particular clinic is capable of using the PDSA model for further projects. Say they want to start a nicotine replacement program, then they can implement this PDSA model and know that it will likely help them in the forward trajectory. Another impact on practice is that the clinic is capable of implementation of state standing orders. So if it becomes a state standing order that this particular clinic can dispense nicotine replacement therapy out of their pharmacy, this clinic will be fully capable of implementation of that standing order, as evidenced by the capability of them dispensing naloxone out of our clinic pharmacy. The clinic is definitely able to change practice procedures. So this goes back to any further changes that happen within this clinic. The clinic will be able to implement successfully any changes that come their way. Since the clients that came into the clinic were being screened for opioid use and were offered naloxone kits if they wish to take one home, there's definitely going to be an increased public knowledge of naloxone, how to use it, when to use it, who should use it, etc. There was definitely added time to the client check-in process with the opioid screening, and the clinic visits were definitely longer if they had found the need to dispense naloxone. The cost of the naloxone kit on clinic pharmacy costs were definitely increased. The 2 naloxone sprays for 2 sprays would cost the clinic $75. The CPR mask was about $3 a piece, and the eyeglass case that held the kit was another $3. So you're looking at least $81 to put together one of these kits. With time, that could definitely cause an impact on the pharmacy costs. The numbers of naloxone kits dispensed also may increase as the public awareness increases. Now, many members of the public know that they can get naloxone at this health department, and they may come back to get more kits. The North Carolina Health Department's dispensing naloxone can help reduce the number of people that die from overdose, which is a Healthy People 2020 objective. So this is important that more of the community is aware that the health department in question is dispensing naloxone kits. With dispensing naloxone, we can reduce the numbers of people visiting the hospital for drug overdose, which overall decreases the cost of health care, which is a triple aim objective. The health department is now an active participant in the county's opioid overdose prevention group that is run through the sheriff's department, which is really important and impacts this practice because now other members of the community organizations do know that we are able to dispense naloxone. One community organization, Chatham Recovery, dispenses and gives out prescriptions for methadone and Suboxone, and 2 months ago they found that they lost funding for their naloxone kits. This organization now is aware, because we're sitting at the table, that they are able to send their clients to this particular health department to get a naloxone kit, which is really impressive. Are there any questions?